Yeah. Hello, good evening, and welcome everybody to yet another podcast on the 10th of every month. This is 10th of May, and today we are on the fourth podcast from the chairperson of the Imaging Science Committee. I, Dr. Neena Malhotra, take the pleasure to welcome you to this podcast. But before we go on to begin with our podcast and invite our guest speaker, I take the pleasure of welcoming our President Fogsi, dear Dr. Sunita Tandulwadkar. I don't think she needs an introduction. A dynamic personality who is the brainchild behind these podcasts. I take the pleasure of welcoming Dr. Sunita to welcome and introduce our series today. Welcome, Dr. Sunita.
Thank you, Nina. Thank you so much. And it's such a wonderful two best friends are together with me. Sonia, it's lovely to see you back on Fogsi platform. You have done amazing work as a Fogsi Infertility Committee chairperson. And I know how many times, Nina, I don't know whether you are aware, me and Sonia, we pick up the phone and discuss difficult cases which we work in our day-to-day practice. And it's always pleasure to have at length long academic discussions with us, with each other. But today you have selected Sonia for your interview. I'm so glad. I'm sure it will be, the podcast which everyone will cherish to hear. Sonia, this podcast series I've started because I just don't wanted those webinars with 5 attendance and every committee chairperson used to do because it's compulsory to do some activity. Others are doing, so what shall I do? And I just scrapped out webinar from our history of Fogsi. I just don't want anyone. But at the same time, it's important that our committee chairperson do some good activity apart from just the CMEs or writing news bulletin or books. And then this idea of podcast where their leadership, where their quality of individuality can come out. So they can select any academic, non-academic, Indian, outside India, political, philosophical, spiritual background, and have a very nice 45 minutes one-to-one discussion, which will be fruitful for them also, and for those who are listening are enjoying those dialogues. So I'm so glad, Nina. I felt I'm helping my chairpersons. But now when we completed 100 plus, I realized what is, I am getting evolved by meeting all those personalities from various background. Means you have a Nitin Gadkari, you have all political, you have philosophical, you have a social, such a beautiful life people are living in. And I definitely feel meeting those 100 faculty, I evolved myself. Every day logging at 8 p.m., it's a huge task. It's huge commitment. But when you are eager to meet and listen to beautiful podcasts, I think this is better than listening to the news channel. I'm glad, Nina, and I know you are such a fantastic clinician, academician, orator, that you will bring out the best from Sonia, and we will have a very, very good session. Thank you. Thank you for having me, and we can introduce Sonia. I hand over to you, Nina.
Thank you, Sunita, for those words of encouragement. I think we look up to you at all the podcasts. So, dear friends, I think 1978, the two pioneers in IVF, Steptoe and Edwards, thought of starting and pioneering IVF for women who had tubal blocks. 48 years down the line, little did these two gentlemen realize that there's a paradigm shift in the kind of women we are helping with IVF. Today, we have a different cohort of women, and to deliberate on a very challenging group of women who are responders, we have none other than Dr. Sonia Malhotra, a name who needs no introduction, a woman driven by passion in pursuit of excellence, has reached the level of what is called a clinical mentor of Nova Fertility. I wouldn't say she's just a clinical mentor. She's a mentor for life for many, including me. A role model who has risen to the ranks with a sheer excellence, driven by the passion to provide the best services. To her accolades, she has been the president of many societies, including the past president of the Indian Fertility Society, Indian Menopause Society. She has chaired many, including the Fogsi Fertility Society, And today, before we really take much time introducing her with her achievements, I think let's start by welcoming Dr. Sonia Malik to this podcast series of a topic which is very apt in today's day of poor responders, which truly are a challenge, not just to our Indian patients, but globally. So welcome, Dr. Sonia.
Thank you.
Thank you so much, Sunita and Nina, for having me here. And just as you said, Sunita, it's a pleasure to be amongst one of my cherished friends. You and I have grown together in this field of ART right from the beginning. And of course, Nina is our baby who has grown to such heights now that she commands the position of the head of the department of the Premier Institute, that is AIMS. So with both of you here, it is indeed an honor for me to talk to you most informally, as you said, because this is not a webinar. This is just a conversation between friends. And I hope we can do justice to this topic, Nina, that you have selected for us, So thank you, Sunita, for this brainwave of yours. You are always thinking out of the box, and you challenge us each day by, by giving us new things to think about and new ways to manage our patients. So that is how we have grown together, and I think we shall be able to do much better as we go ahead, all of us doing things together. Thank you, Nina, for this opportunity.
Thank you, Sonia, and thank you, Nina.
Yeah.
I will be joining the viewers link, but I love Nina. Sonia Malik naam hi kafi hai. What a filmy, beautiful dialogue she got in. Thank you. Bye, and enjoy the conversation.
Thank you.
Thank you, Sunita. Thank you so much.
Thank you.
So as it said, we have a celebrated star today who has been in the IVF field for more than 5 decades. So ma'am, how do you see yourself in the practice of ART as you've grown from the 90s beginning with South End, and today in the last decade or two, you see a paradigm shift in the practice? How do you see your patient profile, or with the available technologies, where do you see the shift in the IVF practice today?
Let me take you back to 1978. You talked about the first IVF baby when Steptoe and Edwards did it. That time I was in college, and in 1978, I set up the first infertility clinic in my college. And believe, like you're saying, what has been the paradigm shift at that time? While they were talking of IVF in the West and talking of ultrasounds and what all, we were very primitive, and we had just OCPs to help our patients with. That means oral contraceptive pills to regulate their periods. Clomiphene had just come in, and we were so scared to use this molecule because all we thought was we are going to land up in ovarian hyperstimulation syndrome. And there were no ultrasounds to monitor, nothing at all, just clinical, our hands to palpate, and that's it. So therefore, we have come from that era to what we are today. And it has been a beautiful journey, believe me, Nina, to be able to witness those changes of so many decades, to where we are today. That is, of course, the technology part of it. But as far as the patient profile that you're talking about, definitely that has changed a lot over the years. You and I have both observed it, but of course, in the early 80s, I would say, it was very, very different because they were younger in age, and when they came to us, and the other thing was they were very shy of this condition. They never were accompanied by their husbands. It was a familial kind of a thing, generally accompanied by either the mother or the mother-in-law. If it had to be hidden from the in-laws, it was the mother. If it was a common thing, and they were not, the mother-in-law had kind of discovered it, then it was the mother-in-law who used to bring her, and the husband would come later on, much later, third consultation or something, hiding behind the door, very submissive, because we didn't find anything in the wife, and we thought it is male infertility. So that was the kind of patient profile that we had. But nevertheless, the advantage was that they were much younger in age, and therefore their egg reserve was good, their ovarian reserve was good. We were getting plenty of eggs those days, good oocytes, and a very good pregnancy rate with our limited resources. We used to make our own filtered water in the labs those days. We did not have media. We used to make our own media indigenous over there. Importing media from other countries was very difficult. There was maybe one or two agents sitting in Bombay. So in Delhi, it was extremely difficult. And then the electricity fluctuation during those days, you remember, they were very, very difficult. So therefore, we were always struggling with that in summers. Patients were also asking us this question repeatedly. Is it going to affect our success rate? And yes, we couldn't confidently say that it's not going to do that. So numbers of IVF cycles were less. So things have really moved ahead. And we really are very, very lucky to be in the best environment these days. But the patient profile has changed. The women of this country, or maybe all over the world, have progressed because of women liberalization. But that has taken its toll on the reproductive health of the woman. She is not what she used to be many years ago. Now we have a singularly older woman, maybe about 35, as you also know in your own centers. Now there is no difference between the government centers as well as the private centers as far as the patient profile is concerned. We are getting the same kind of poor ovarian reserve, whether it is us or anyone else. So that we are struggling with, and therefore we are struggling to get number of eggs, and we are struggling to get good embryos and hence a good pregnancy rate. That's how I would say. Earlier, it was a case of plenty. Now it is a case of scarcity. Not only women, also men. Both of them. They are hit very badly by what is called modern age and the technology or whatever the societal changes. But yes, we are all suffering.
I know you beautifully brought out these words and given us a very good, overview. And truly, I think, isn't it paradoxical? While we're evolving in technology, we've not evolved in our pregnancy rates, and you really, really highlighted.
Absolutely.
So in your practice, what percentage of your patients that you get today are poor ovarian response or poor responders or poor reserves? I think this is just, many shades of the same, I would say, kind of women. How do you see them today with a couple of them? What percentage you see in your practice?
The average age of the women that I get these days in the clinic is 38. It is amazing, when I was a student, we used to say 35 is an elderly primary gravida. We were so scared when we would have an elderly person, how are we going to manage her pregnancy? And here we are doing it every day. High-risk pregnancies, high-risk patients have increased because patients are getting married late or whatever the reason. We'll come to that a little later, maybe, as we go ahead. But yes, the age definitely, and the profile of the patient, as I said, has definitely changed. So the percentage would be about 60% of the patients are poor ovarian reserve. It's very high, Nina. It's terrible and it hits us very badly. So that is where we are struggling. Majority of the patients are coming with a poor ovarian reserve, and we really do not know where to look and what to do.
So, truly, Edwards and Septo up in heaven would really be wondering what we people are going to do with this kind of number that we are seeing.
Well, so, they produced a child with one egg. I suppose we'll have to do the same thing, produce a child with one egg.
They produce. Yeah, so I think. So what do you think, as you highlighted, 60% is an amazing number. I think it's an alarming number for us to sort of understand why the dynamics have changed. So what do you think has been the reason why we see? Do you think it's just women who are deferring for pursuits of their careers, or there are more reasons, I would say, delaying fertility, or there are reasons beyond delaying fertility? Because we do see a lot of surprise poor responders as they come even in younger age, though less, but yeah, we do see. So what do you think are these reasons for alarming numbers?
It's actually, I cannot pinpoint the exact cause. I cannot pinpoint to the exact cause. But yes, we are all sort of speculating and thinking that there has been a dramatic change in the kind of environment that we have around us, be it the air that we breathe, be it the food that we eat, So I think that is more to be blamed rather than the lifestyle of the patients, because basically, please. Basically, we do not know what to do with the food, toxins everywhere, and food processing, and even the water that we are drinking is polluted. We know that there is so much of extra harmful estrogen. I'm using the term in colloquial language because this is also for non-medicos, this podcast. So basically, we are drinking all kinds of poison. We are eating all kinds of poison. So probably that is taking a toll on our genetic structure nowadays, and hence causing these changes. What we in our own language as doctors call epigenetics, that is changing, and hence we are finding this change both in the men as well as the women. Look at the pollution levels in the air. We are not able to manage that also. And hence, even though we have air purifiers in our homes, etc., but how many people are actually using those in the country? A minuscule number. And hence, we are finding that there are these things. If you try to decipher the causes in the urban class as well vis-a-vis the rural, you find that the causes for this kind of a thing is different. In the urban class, it is more of the lifestyle factor because, like we said, they're getting married late, they're having jobs, they don't want a child. And interestingly, a study was done in India only, which showed very clearly that the number of children that a woman produces is directly proportional to the education status of the woman. The more educated she is, the less the number of children she wants to produce. And that is a fact. We know that in the hinterland where they are uneducated women, they will keep on producing children because they don't have a voice of their own. So therefore, in the urban class, we don't find more than 2 children. So that is another factor. The more the woman is liberated, the more she thinks about herself, her own being, then she is not going to be bowed down or cowed down by the family to keep on producing, children one after the other. But in the rural belt, you find that the reasons are different. It isn't that they don't get married early, they do. But there is such a huge number of infections over there. The infections in the countryside are humongous. And you know that in India, our biggest problem is that of tuberculosis. But that is not what is not pointed out by people, is that it also affects the reproductive system and the female reproductive system as well as the male. In the male, it may become obvious in the form of an ulcer or something or the other, but in women, we just don't know that she has a problem, and her tubes are blocked, and also her ovaries are knocked out, so the ovarian reserve is gone. So such things are more important in the rural belt than the fertilizers and the pesticides, again, as acting as toxins over there in the rural belt, as against the urban belt. So these are the various factors, I think, which have caused this kind of a thing. Our green revolution, which has actually helped to feed us, has caused these problems also. We didn't think about this.
I think truly we are paying the price of modernization and civilization. And I think you will come across patients, as I do, when a young lady at 36, 37 said, why can't I have a baby when my grandmother delivered a baby while she was 44, 45? My mom was... So, that are kind of situations which are very hard for us to kind of answer. So, thank you so much. You brought up these things so beautifully and to understand. But as we move forward, we as clinicians and as doctors, we always know that this is a very heterogeneous group, There's women who will be young, her reserve is not so good, and yet there'll be somebody who is 37, 38, but her markers are good. But yet she doesn't give us the outcome we sort of are looking up to because her ovarian reserve markers, as we say, are good. So do you think that these kind of patients are a challenge, or some way you feel the way we are classifying the women with those newer classifications or the so-called positive, has it really mattered and made you think on your mindset or your planning, or you feel, no, I will still go by my old wisdom or judgment? Or how do you really see the current, dynamics of the definitions, nomenclatures? Has it really helped us?
Well, the nomenclatures are still evolving, I would say. We haven't reached what is perfect. We still have subsets of women who don't fit into these criteria at all. Like you said, there may be a 40-year-old woman who doesn't fit into that criteria. She's not a poor responder, and she has a very good ovarian reserve, and she produces quite a lot of eggs. But having said that, Nina, again, we do not know how many normal or how many good eggs is she producing. Are they all genetically normal? Are they abnormal eggs, or are they normal eggs? What is the quantum of normal children that she might produce out of those eggs? Because what we have realized over the years is that is a very interesting sentence that Bart Frauser, as you know, wrote once. We have to realize that every egg is not going to give rise to a pregnancy. And we do not know what is the difference between that egg and the other eggs, we cannot differentiate between an egg which is going to give rise to a pregnancy vis-a-vis an egg which is not going to give rise. So we just keep on stimulating everything. That's why I said maybe we'll be wiser like Edwards and Steptoe if we produce only one. So therefore, the classification of these poor responders probably will also change. Not only them, but other patients also. But yet, by looking at not only the type of patient, for instance, we had the WHO types, to the response. We have actually graduated from the type of patient to the response of the patient. So in every type or every group of patients, we have a poor responder and a hyper responder and a normal responder. So we have reached some kind of a semblance of order. We do find that we can judge our patients in a much better fashion. But I still find that there are patients who don't fit into any criteria and they give us a big surprise. As you said very correctly, that, we may not be having a woman who is actually a poor responder at age 45. He's producing wonderful eggs. Today, I had a patient who said, "Madam, you are telling me I don't have eggs. And my friend who is just 2 months older to me has produced 2 children in the last 2 years. So how is she having good eggs?" So these are answers, these are questions to which I have no answers. And I can't classify her. So therefore, yes, like you said, we still are evolving.
Yeah, fantastic. I think you really put it right. We are still learning, and every day we understand that one patient is really my teacher, and next day there's another one. So, we know that all of us, patients are the same. They're going from one clinic to other, seeking advice from you, maybe me, or all our clinicians. But when we have such kind of patients, do you think you do take a lot of time, but do you think the counseling that you would do to this kind of a patient, vis-a-vis somebody who has a male factor, does it really matter that we talk to them more, or the other side, if we talk to them more, is it going to deter them to come forward? So how do you sort of strike a balance? Because, there is an information overload here, and then there's something where I feel, I need to keep the couple in loop. So how do you sort of strike a balance when you get couples like this? And perhaps they've tried cycles, you get people who have tried 6 to 7 cycles, and now they won't kind of give up. So how do you really kind of take this kind of patients in your
This
practice?
This has become a common feature for all of us. People have, like you said, we have so much of information on the internet. We have so much of information all around us. And in India as a country, we are very, very neighbor-friendly people. Our neighbor is our best friend. Our best friend is somebody who's grown with us. So every person who meets you gives you an opinion. So the patient, when she comes to us, is already overloaded with information as well as opinions. More than the information, it's the opinions. It's not just Google doctor who's giving her an opinion. It's all her friends, all her neighbors, her relatives. Everybody has given her an opinion. And therefore, it becomes a big challenge for us doctors to actually counter those opinions and give our own opinion. So counseling has become a major problem for all of us, because we have to first listen to what the patient is giving, what information the patient is giving us, and then clean it, and try to give her what is correct and tell her not to do, tell her to, or maybe sort of decry or prevent her from using the wrong information for her benefit. So that is becoming a challenge. We have to sometimes be a little rude to them, which they don't like. Sometimes we do become blunt with them. Nobody wants to hear negative things about themselves. And these patients will never acknowledge the fact that they have a problem. It's always the doctor who is at fault. The patient is never having a problem. And if she has, it's your role, and it is your duty to solve it. I've come to you, so you solve it. Why are you asking me to do it? It's your problem. So therefore, counseling today has become a major part of our treatment. It is every visit to the doctor is a major counseling session. And although the ART rules say that we must have a counselor, a psychological counselor in our clinics, it is the clinician who is the biggest counselor for these patients, because the patient only understands the language that you speak. They don't want to listen to what the other doctor tells them, because they have come to you. You are the person who's going to treat them, and therefore whatever you tell them, whether it is right or wrong, is going to be. And then once we have spoken and told them given them our opinion, then they go back and think about it, talk to their friends again reinforce what has been said, and then come back again and say, no, you were wrong. You didn't say the right thing to me. This is what I wanted, and you have told me this. So, Nina, this is happening every day with us. But with every patient, we are learning how to counsel them, and when I talk to people in my family, I say, you don't understand and you don't realize I'm the biggest counselor. And I can counsel anybody because my patient has been teaching me so much of counseling. All the time we have to tell them this is right and this is wrong, many times hiding things from them, many times telling them things which they do not know and they should know. So, but then at the expense of losing them. So many times the patient doesn't like what you've said to them and she never comes back to you because she doesn't want to hear what you're telling her. But you have to sometimes say it because obviously you're not going to get any results. She's not going to get pregnant, but she doesn't like it. So such things have been, I think, Nina, you would have also gone through the same thing every day. Patients are discerning, patients have become enlightened. And it's not just the urban girl, it's also the rural girl. She may be illiterate, but she has that sense of opinion. She will give her own opinion, and very, very strongly. She doesn't budge from what she thinks. And you have to really rack your brains and think of a method to actually convince her and tell her, no, beta, you're wrong. So it is a major challenge for us. But yes, we are there to take the challenge. That's part of management.
I think I would echo the same sentiments because at the end of the day, you have to be passive listeners, but you have to make them unlearn a lot of things which you say as they come so opinionated, so fixated in their thoughts. And I think it takes a wee while of a time for us to sort of tell them how we go. But I think at the end of the day, we have to be really realistic because there's some things which are beyond the realms of science, beyond the science, the realms of even the technology that's evolving.
Yeah, absolutely.
Absolutely understanding them may not be very easy, but we do see that they come with that mindset. Yeah, they will go back with the baby. And I think that is kind of a hopeful vision that they want. But where do you see today that there are so many add-ons, adjuvants, their prescriptions are sort of laced or cocktail coming up. Do you really believe that they help? Or do you think, yeah, they would help only a subset? Or no, let me try everything and it would sort of work on and yeah, she'll be fine. I don't mean you to give me a very kind of a generic, but some kind of, anecdotal cases where some government experiences where you say, no, I would really want to try this one. So from your experience.
Yeah, well, you have hit the nail on the head, because adjuvants have been something that have been around ever since we started practicing infertility because we had very little in our armamentarium, I'm telling you. So therefore, but the only thing, Nina, is that I believe that it is not always evidence that teaches us, because basically evidence has to be created by using something. If you don't say use something, then you will not be able to say that this is good or this is bad. Suppose you have two fruits lying in front of you, and one of them seems to be raw and the other one is ripe. How are you going to judge whether this one is ripe or raw unless you eat it? So therefore, the same applies to medication. But as you rightly said, everything may not be suitable for everybody. We know we have allergies. We know we have problems with our systems, and everything cannot be given to anybody. So that kind of a discerning sort of marker is not there for every adjuvant that we use. And therefore, we tend to overuse everything for every patient, trying to say, okay, acha bhai, shayad ye kaam kar jaye. But it may not, So I don't think we should be loading them unless, science is evolving every day. We are coming and, meeting we are sort of finding more evidence in our studies, and we are finding more evidence through our own practice. And if we are using something for a long time and we suddenly find that, okay, this one is something which we have, which we shouldn't have missed, but we have. And so you start practicing that way. The biggest example that I would give you that India has given to the world is genital tuberculosis. the rediscovery of genital tuberculosis, I would say, because it was lying, hidden somewhere, and we started working on it. The West was not bothered. They didn't even think about it. And in fact, you know yourself that they were laughing at us when we started talking about it initially. But now it is accepted because we have created that evidence. We have shown them that it exists, and we have made guidelines out of it, isn't it? So that way, I think the problem with us as Indians, as doctors, is that we are unable to give that kind of evidence to the world because we don't have enough resources, and we don't have the kind of fixed trials that we should be doing. Therefore, our half-hearted, so-called anecdotal trials are what is causing the problem. But as Indians, we are very logical, Nina. Whenever we treat somebody, we have something in our head. We think logically and then put the patient on something, thinking, "Acha, this is what it does. Maybe it is going to help my patient. Let us try it. Let me try it." So that is how we start looking at these things. So sometimes we fail, and when we fail, we stop using it. But if we do get success, we keep on using it. I think like that because that is how did we know that a pulse is a bigeminy pulse when we touched it and felt that it was beating like that. So that way, I feel that if we don't try, we will not get anything. We should try and create evidence and then go ahead with that. But adjuvants may not help everybody. They will help some subset of patients. And that is the best thing that science has given to us, is personalized medicine. That every patient is different and hence has to be treated differently. That is something that we have learned over the years in infertility, that we have learned in every branch of medicine now, and hence we are better off. Our results seemingly are better because we are treating them with much more intensive insight into their own systems. When they listen, when they give us big histories, when we are talking about counseling and they talk rapidly about their problems, we are actually gaining an insight into their personality and their problems also. So that helps us to treat them. That is my own opinion. But yes, you may not agree with me. You may be different. I don't know. But evidence, yes, I feel has to be created. Unless and until we create evidence, we will have to use these adjuvants as they are.
Yeah, you've brilliantly pointed out. And I think, there's not just evidence, there's experience-based medicine. And IVF infertility cannot be in the realms of evidence because to do randomized trials on such patients may not be easy.
Yes.
Because this is a very difficult group of patients, unlike most trials which be on cancer or on things where I think it's still feasible. You really brilliant out.
And also, you know that now most of us are depending on polls. We have the Delphi consensus, we have this consensus and that consensus. So why are we doing that? Because that is all opinion polls, isn't it? That is basically because, like you very rightly have said, we can't have these trials in these patients because it's very difficult to do human trials. We can't subject them to this like guinea pigs. And therefore, we have to do it. They are as it is. We have to resort to these methods and hence do trials in whatever way we can. Opinions, I would say. We would have opinions. Didn't I?
Good. So I know you had decades of experience. You all kind of, combination permutations. Are you fond of some particular kind of stimulation protocol where you say, "Oh my God, I've done everything. I've tried it for loads of pain, but I somehow swear that this works in my group of patients," which I would. So do you sort of think, or you say, no, every woman is different. I'll kind of make her recipe, put it in a different kind of thing. I know it's a difficult question I'm putting across, but you have to sort of learn from each other. I thought I want to hear you. Are you a big fan of some product, even though there are companies coming and vying for one thing or the other? How do you really take that? Because it becomes very challenging from their previous histories, or you sort of say, no, I will try my Nova or the South End protocol. That's something that's very, very my patent. That's my patent. I want to hear your recipe.
No,
your recipe.
You know what? Again, you also know this, and I also know this. We have changed and we have evolved from the agonists to the antagonists, and we found it much more easier but like you said, I generally talk of personalized medicine, and therefore I see the patient and then decide what protocol to use. It's not just one protocol in my center. I use the protocol which seemingly seems good for that particular patient, and then I do the ART cycle. But it's not always कि अच्छा भाई bandwagon है, चलो सबको antagonist protocol ही दे दो, या चलो सबको agonist ही लगा दो, because मेरे को तो उसी की आदत है. It's not like that. I keep changing from one to another, and of course, like we have so many new things come up. You know the various new protocols that we have. So we are experimenting with those as well, because some of the patients do well with those. And we do find, like, of course, let's take the subset of donors. Now, we are not, earlier we were doing we were batching our patients. Therefore, we were, sort of doing, and we had no freezing at that time. So we were using the long protocol for the donor as well as for the recipient, and bringing them together on one day and starting the protocol for both of them. Now we don't have to do that. We are stimulating the donors with a different thing, and we try to minimize their injections. We are giving them progesterone, PPS protocol also, so that you don't have to give antagonist. It's cheaper and easier for them. So these things are happening because of the type of patients that we are getting, and also because of the evolution of infertility management. So with that, yes, times have changed, and so have we. I have, at least, I don't use one protocol, no. I keep on changing depending on what kind of a patient I have. That's it.
So thank you so much for giving me this insight that, yeah, one size doesn't fit all. She may be the same woman. You don't cross the same river twice. She will be the same woman. She may have got another protocol in the previous cycle, but this time you know that this hasn't worked. So let me try. And I think it's a hit and try.
Yes.
So I know that there is a big, push towards regenerative medicine. Or perhaps we are helpless, we have no choices. So today, in the kind of, again, we don't have big evidence there also. It's again experience with, where do you see the role of pushing in PRPs, stem cells, all the likes? Because, there is again the pressure. I want a baby. Maybe you have the magic wand. And does this PRP work like a magic wand? How do you see that? Because you've been trying it and you've been giving these kind of patients all the sort of hope and help.
I think it's hope and hype both, because basically the patient is aware and she knows about it. Most of the patients who come to us now are aware of these regenerative techniques, because not only have they used it for reproduction, we are the last ones actually where it is being used on the skin, derma people, as well as the orthopedic people, these even the CNS. These people have been using it much more frequently than us. We are the last ones, I think, to start using it. Interestingly, it is now also being used for male infertility. So the andrologists are also using stem cells as well as PRPs for increasing the sperms, in the testes. So therefore, now that it is being used, and the biggest thing about its usage is that it's not harmful, because it's autologous. It's coming from the patient's own blood, and therefore the chances of having any kind of adverse effect are minimal. The stem cell may be producing better results, I do not know, but the cost is prohibitive. But PRP is relatively cheaper as compared to the stem cell, and seemingly gives the same kind of results. Therefore, I would prefer to give PRP, knowing that I can't give 100% results. It's an adjuvant, and so let us use something which is simpler. Because, Nina, even pricking the ovary is a stimulus, and that also can stimulate the ovary to function again. We know that because of the changes in the enzymes that are being produced, or the cytokines that are being produced. So therefore, why not just give something which is simpler, rather than doing a tedious process and then, making her do it again and again. It's not once that we do it. We have to repeat it again and again to be able to have some kind of a result. And then of course, we tell them that it may not help at all, but then sometimes it does, and therefore you become happy that it has, like you said, adjuvants. This is also an adjuvant at the moment. It's not a definitive treatment, but yes, with these experiments, maybe we'll hit upon, or we'll come, we may be able to find something which is absolutely, it hits the nail on the head, like I said, and we may be able to do better. But we'll have to do these permutation combinations, otherwise we are not getting anywhere. One egg is not enough to have a child. But then, having said that, now that we have both returned from Japan very recently, We know over there that they don't use any of these systems, any of these methods. They are just retrieving one egg, and then going ahead with it. They are just doing egg collection. But the difference is that for them, 6 cycles are free of cost. Here, the patient pays from her own pocket, and we try to give them the best in the first 1 or 2 cycles. We don't want them to stretch to 6 cycles. Patient will not be able to afford that kind of money. Hence, we try whatever we can in the first 1 or 2 cycles so that we get the best results. So there is a difference in the type of patient and the country that we are in. So therefore, we have to do what we have to.
Certainly, the practices change as we change in societies, as we change in the economic behavior of our patient. And I think all that really, and I certainly would say that even one egg matters. That one extra egg is for a woman and a couple in desperation. I think that does matter. So, having really not really understood or little understood, we know that we've got a lot of gizmos. Technology has moved ahead. Undoubtedly, undeniably, embryology labs are the best that we can sort of think of in today's day and age, looking back at how you describe creating your own milky water, balancing the salts. And today you have everything available. So do you think with this advanced technology, with the available, embryoscopes, PGTA, all those kind of oocyte activation, do you think it's really, really helping us? Or it's just a kind of a hype that we have? How do you really see it? Because I know you're not a lab person, but you work so closely with the best of the teams. How do you see the lab helping us?
The lab is the heart of the whole thing. But again, I keep repeating to everybody that if the clinician is not good and is not able to give the lab the best eggs or the sperms, how are they going to create the best embryos? So it is something where we work hand in hand, and we can't say he is better than me or I am better than her. We are both equal, and our expertise matches each other. Unless and until we produce good things, they will not be able to do it. But having said that, the lab technology has advanced a lot, Nina. We all know that. Our basic labs, the interesting part is that the basic labs that we had about, say, 20 years ago, 2 decades, were giving us a 30% result, right? Now, 30% pregnancy test positive result, right? 30 or 40. That is what we used to achieve in those days.
Yeah.
Nowadays, we have a 60 to 70% pregnancy test positive result. Agreed. But with that, the clinical pregnancy rate falls. And ultimately, the live birth rate is again the same, 20 to 30%. It never rises beyond that 20% or 30% level. So whatever we may do to our labs and whatever way we process our systems or whatever we do, somewhere that magic figure of 30% is not going away from us. It's still sticking to us, although the viable embryos that we are producing are much more because pregnancy tests are positive. But biochemical pregnancy is still more than the clinical pregnancies that we achieve. So that is my take on this whole thing. However, having said that, we still are able to, achieve much more because that 20-30% of live birth is not what we were achieving with the 30% biochemical pregnancy rate at that time. Unfortunately, in those days, we were not looking at the live birth rate. We were not following the patients in so closely and looking at it. Now we are looking at the whole spectrum. And hence we know that, this is the number of patients that are actually coming out of our labs. So it is making a difference, definitely. And the technology the type of airtight control we have on the temperature, on the humidity, on the gases that we use for our incubators, all that has changed. And we also have, as embryologists, have realized that we have to really, really have a close, tight control over all these things in order to get good results. Our incubators are much better than they were earlier. And we also have restricted the number of times we open our incubators and close them. And also with the embryoscope and new technology, we know what are the changes that are taking place in the early stages of the embryo development, right from fertilization onwards. We know the changes that are taking place at cellular level or even more than that, which we were unaware of earlier. And we are starting to correlate them with later things. Okay, ये हुआ है तो अब ये embryo तो अच्छा नहीं बनेगा. So therefore we are becoming better Jyotishis, I would say. We can predict better, and hence our results are improving. That is how I'm looking at it. So if you have a 70% say pregnancy test positive result, then I think that the number of live births that you are going to get is amazing. It's actually much more than the 10 or 5% that we used to have in earlier days. That is how I look.
Do you still believe and say, I swear in a correspondent to do a PGT in a single blast, and that's or you say, no, I may never be able to reach, because that's how your patients come very, very ambitiously asking you, how would you sort of take that? That's something that comes. So how do you talk to that kind of a couple? I'm ready for a PGT. I have all the money. Give me one blast.
Yeah, okay. It also depends on the patient. Now, again, I always tell my patient, this is my favorite tagline. You have come to me for a desire, not for a disease. This is what I tell them. So now you have to decide what is your desire. I have informed you. I have told you everything. You have to tell me what you want so that I can take you along with me to reach that, to achieve what you want. So therefore, the ball is in your court. I have told you, if you want me to give you PGTA on one blast, I will do it. But if you listen to me and say that, okay, collect 3 or 4, and then we'll do a PGTA on those embryos and decide what we have to do, we can do 2-3 cycles. We tell them to collect. But if she is adamant and she says, I'm not going to do anymore, I decide only on one, I do it. Because after all, it's the wish of the patient. It's she who has come for a child. I have only to help her.
I think best are the patients who say, doctor, you are the one, you wrote, you take my decision. I think that time you feel quite relieved, don't you? You feel, they've given us the opportunities and we'll not sort of fool them or mislead them.
No, we don't mislead them ever. We don't mislead them ever. It's just that they don't believe what we are saying because they've come with a fixed idea. So they want to hear only that from us. Yeah.
As you rightly said, that we are trying to become some bit of a Jyotishi and maybe sort of kind. And we are in the world of precision medicine or predictive medicine or whatever names you say. I would say, do you think that there are times when you would say, yeah, let's be blunt, let's be very, righteous in a way, tell them, look, let's quit, let's move to donor eggs. And it's a very hard decision for a lot of couples to take.
Yeah, absolutely.
Not be biological, have their own biological, offsprings. So when do you think, I'll say, enough is enough? Or you say, no, you should try the 9th. Or there's no, I should say, no, the second IVF cycle gives me a lot of warning. So how do you take? Because oocyte donation, I think acceptability is going down, as I would say, or you say it's still the same in couples in your practice because...
It is the amount of desperation that a couple has to have a baby. Like I said, it's your desire. It's not mine. So I feel that the educated class is not as desperate as the uneducated class. They still have those cultural biases behind them and they are bogged down by what the society is going to say about them and they don't have a child. So the famous quote that these people have is, डॉक्टर साहब हम तो बच्चा लेने आए कैसे भी दे दो अपना दो किसी का दो कहीं से भी उठा के दे दो. That is the line, that is what they say. And in that patient you don't have a problem in convincing them even after one failure कि भाई तुम तो अब donor ले लो अब ये नहीं होगा. So they will agree immediately. वो donor embryo भी मान जाएंगे. They won't even say कि नहीं हमें बच्चा चाहिए हम बच्चा लेने आए कुछ भी कर दो. So that class is very easy to treat. But like you said, there are people who want their own genetic child. They will not listen to you come what may. You tell them one embryo is bad, 2 embryos bad, they will go on trying. I was exasperated by a couple who did 13 cycles with me. And she still would not want to do a donor because she said, I want my own. Under any circumstances, I want my own. The 2 or 3 times that we did a PGTA on single embryo, as you said, one embryo, will you do a PGTA? We did it. It was aneuploid. Yet she didn't, there was no closure, Nina. She just wouldn't agree. So then now she's gone away to another center. She's still doing the same thing. She hasn't relented, both of them. So therefore, that kind of patient is also there, and we have to respect their sentiments as well. We can't say कि नहीं भाई तुम हमारी सुन लो donor ले लो. क्यों भाई नहीं लेते? So there is a difference in the type of patient that you have. And many times, Nina, I feel when I'm looking at a husband or when I'm looking at a wife, I really wonder, they have actually chosen each other after seeing each other, meeting each other, being with each other. जब शादी के लिए proposal आया होगा तो देखने तो गए होंगे ना. Now we're suddenly telling them to get another one. You know how difficult it is to choose another third person when you're so happily married together. So that is a psychological angle to it, and sometimes I really feel scared to even tell them, because I feel they're so well matched. My God, why am I telling them to have a child through a third person? So again, like I said, we have to really think of the desire of the person, the desperation. I can't forget the quote of a doctor. He's from Australia. I don't remember his name. He said, we are like the oncologists. They die when the patient dies, but we are dying every day when we tell our patients that they can't have a child anymore. So we also died. So it's a different kind of a death for the patient, but also for us. So, it's very psychologically ridden. Our branch of medicine is more of psychology than science, I feel so. We are
Absolutely.
many times I tell them that, I tell my juniors, you have to disassociate yourself from the patient. It's very difficult. For the patient to disassociate with stress is equally difficult, but for you also to disassociate with that stress is very important, because ultimately, when there is a negative pregnancy test, repeatedly, you will become like Wahida Rahman in Khamoshi, thinking about the whole thing and relating it to your own self. Kaise kare? We are so attached to our patients कि हम ही पागल हो जाएंगे. So you have to have that kind of a disassociation and disconnect also. Although you feel so much for your patients, but then how will you think rationally if you are so emotionally charged with them? That is
Truly, it's not just fertility science, it's behavioral science that we are evolving each day with our patient. We didn't realize we've been chatting for more than 55, 56 minutes now. Wonderfully. But I think before, I couldn't realize that it was such a beautiful flow of your thoughts, your experiences. But I won't close my podcast, because that's the question which I pose to each and every guest of mine. And I think you will be we'll not let you go without that.
My
and I know that I know, because I've always got most celebrated friends around, and you are one of them. And I would say, of course, a very celebrated, senior that I look up to, a role model. How would you describe your mantra of success, the journey that you had, which has been very memorable, and as we look up to you in your years? So I always want your way of defining success, and what would be your advice to the generation who looks up to you and yearns to be another Sonia Malik?
Oh my God.
Yeah, absolutely.
See, I don't know.
Flattery. There's no flattery. There's honesty all here.
No. I don't know what has led to this kind of a thing, but only thing is I generally feel so, and I say this, that you have to be honest to yourself first. If you have a conscience, never do anything which pricks your conscience. If you think that you have taken a decision which is going to be helpful, even if it is not helpful to the patient, but it is the right decision for her, then that is the correct thing to do. This is what I feel, and this is how God has guided me, that do whatever is correct. हल्की इच्छा मत कर, कर्म कर, हल्की इच्छा मत कर. So that has been the mantra कि करते जाओ, देखते हैं क्या होता है, because basically do no harm, as we have taken the Hippocratic oath. We do no harm is something, and then do something which is correct, which you think is correct, and with which your conscience. I'll tell you, I once had a patient, very initial days of our practice, when we used to have only 2 or 3 patients in a month, and this one patient did not form any embryos. So I asked my friend, he was the anesthetist, I asked him, I said, this patient has not formed any embryos. What should I do? Should I do a mock transfer, or should I tell her the truth that you don't have any embryos? If I say that to her, she won't come back. But if I tell her, then she may come back and we lose it. We are going to. So he said to me, what does your mind say? I said, I don't want to tell her. I don't want to tell a lie. I want to tell her that she hasn't got it. Then he says, finished. You say it. It doesn't matter if she doesn't come. We can do without her also. So we both told her that she doesn't have any embryo. So therefore, we didn't do a transfer. Obviously, they were disappointed. But Tina, After 2 months, she conceived on her own. ICSI patient, she conceived on her own. So, we felt so, and then she came to us. And that time I used to do obstetrics, I delivered her. So I didn't lose anything. So these little things in life have also taught me, be truthful to yourself, do the right thing, and nothing will harm you. It may seem that you are harmed. It may seem that a patient is being very, very, sort of angry with you, or he's very annoyed and something, but eventually it turns out all right. So that has been my way of practice. And this is what I keep telling the juniors also, that is what I say, ethics and honesty.
Thank you so much. That was really the icing to give us those pearls of wisdom that you have to live up to your ethics. And I think you chase your passion, successful chase. That's, I think, what you give us.
Thank
so
you
holistic,
for
so
this
beautiful. Thank
wonderful
you so much, ma'am.
conversation.
It has been a pleasure to have you, and we loved having you.
Thank you, Nina. It was a wonderful conversation. I've enjoyed myself so much. God bless you. It's been a wonderful, wonderful experience. Thank you so much. Thank you.
Thank you.